Hodgkin's lymphoma is a type of blood cancer that starts in cells of the immune system. Actually, all lymphomas are blood cancers that start in cells in the immune system, but Hodgkin's is one in particular that comes from what we consider to be broken B cells, and there are certain cells that we can see under the microscope that differentiate it. The main differences between Hodgkin's and non-Hodgkin lymphoma are the cells that are involved. So patients who come in with Hodgkin lymphoma can have the same symptoms or no symptoms or different symptoms than people of non-Hodgkin lymphoma. They're both blood cancers, but I think the differentiating things are Hodgkin's, there's really only two types. There's classic Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma, whereas non-Hodgkin lymphomas, there's about 80 subtypes at this point, so a much more common type of lymphoma. Hodgkin lymphomas tend to have preference to be in the neck or chest area, in the upper part of the body, and spread in a way that is somewhat predictable where it goes kind of in close proximity, whereas non-Hodgkin lymphomas can show up anywhere it wants in the body, but tends to be less easy to track. So like might have like a lymph node in the neck and then a spot in your leg bone or something without continuity in between. Patients with Hodgkin lymphoma can have no symptoms at all, but some of the symptoms that are most common are what we call B symptoms. So where patients have fevers for no good reason, drenching night sweats where you really have to change your shirt or your sheets, real sweaty, weight loss for no good reason, but there are some non-specific symptoms as well, like enlarged lymph nodes, which tend to be not painful. Fatigue can be a common complaint. Itching is something that some of our Hodgkin's patients have that can be really annoying and problematic to them. It doesn't always come with a rash, but the good news is those symptoms tend to get better with treatment pretty quickly, so if you have them, they go away pretty fast. Hodgkin's is diagnosed just like any other lymphoma, which is by a biopsy of some kind. So it's really hard to find Hodgkin's in the blood. Most Hodgkin's patients are diagnosed either by a lymph node biopsy or by a bone marrow biopsy, though sometimes it'll show up in weird places outside lymph nodes and an organ biopsy, let's say, would be needed. But most people get diagnosed by a lymph node biopsy. And the bigger the piece of tissue we get in the beginning, the better, and the more likely we are to get the diagnosis right the first time, instead of people having to go back and have multiple biopsy procedures to get a clear diagnosis. Newly diagnosed Hodgkin patients have options for frontline treatment, and those options are determined based on their stage, where their lymphoma is, and sometimes their age, because a lot of the treatments we use in younger patients are hard to tolerate for older patients with Hodgkin's. So most patients who have early stage Hodgkin's, meaning stage 1 or 2, will get chemotherapy alone or sometimes chemotherapy with radiation. And patients who have advanced stage or stage 3 and 4 Hodgkin lymphoma will get chemotherapy alone with radiation really only as a backup plan. There are two main regimens that are used today in Hodgkin lymphoma. So for early stage patients, we still use ABVD, which we've been using for decades. So that's adriamycin, bleomycin, vinblastine, and dacarbazine. And for advanced stage patients, there was a comparative study that was done several years ago now that showed that a combination of drugs we call BVAVD or sometimes AAVD, if we're using the brand name, actually does better in those patients than ABVD. And so the substitution there is the B is no longer bleomycin, it's now brentuximab vedotin, but otherwise the drugs are the same. Initially, we had little options for relapsed or refractory Hodgkin's patients other than stem cell transplants. But then, probably almost a decade ago now, a targeted agent called brentuximab vedotin, which targets a marker on the surface of the Hodgkin cells called CD30, became available. That medicine is called brentuximab vedotin, so it's a little bit more targeted and specific than chemotherapy would be. And then the second class of medications that are fairly new in Hodgkin lymphoma are what we call checkpoint inhibitors, and there's two of them. There's nivolumab and pembrolizumab. And those are all treatments that are not chemotherapy per se that we can use to treat recurrent Hodgkin's or refractory Hodgkin lymphoma. The trouble is we are starting to use those earlier in lines of therapy, and so what are we going to use, or what are going to be the more common treatments that we're going to use when we've used those up in the beginning, rather than waiting to see if people need them later. And I think there's a lot of research and new drug development that has to happen in that space. Depending on how patients have responded to their first treatment they got for Hodgkin's, there are a number of treatment options for relapsed or refractory patients. One would be a different kind of chemotherapy, and there are 4 or 5 of them that we commonly use, sometimes in combination with novel agents like brentuximab or a checkpoint inhibitor. Radiation is also an option for patients with recurrent Hodgkin's. And then we will sometimes do what we call an autologous stem cell transplant, which is not really a transplant at all because it's just high doses of chemotherapy and their own stem cells given back. And in cases where it has come back multiple times or people have needed multiple lines of therapies, some young healthy patients will still get an allogeneic bone marrow transplant, but we're doing that less and less when we have newer and better therapies that have gotten approved. So I guess in short, there's a list of several things that can be done in the setting that people need treatment more than once, and it's individualized a bit based on what they got to start with and how well it worked the first time.